I don't know with this if I can share my screen or not. This Hello everybody, this is Dr. Abbasi. This is the first time we are trying this, so I'm hoping this enable me to share my screen because obviously we are going to talk about images and so on. So um, let me see if this enable me to. Hi Christina, I see you are online. Welcome. Um, Obviously, let me put my headphone if it's. I don't know what the quality of the sound is. I apologize again. This is the first time I'm using this venue for this. Um, so I have the pictures on my screen, and now let me see if this system let me share my screen with you. Huh. Well, maybe I should just do it. Say one more time. The network is slow. Yeah. So, and I'm not sure if this venue let me actually share one of my screen with you or not. But let me see. Huh. Well, I can do this. Would that work? So let's do it old-fashioned way. Yes. Okay. So Neil is there. Christina is there. And the quality is maybe a little shaky because I'm holding it right now with my hand. But let me find a way to get rid of this shakiness. And we just, yeah, okay. We are getting somewhere. Apologize. We are going to troubleshoot it eventually. Okay, I think that might work. So, we talked last time about reading this, and I'm just going to describe it. I have a better way. Next time we are going to do it with more interaction. But for today, I'm going to just do a series of how I would read that in a more professional way. I would describe this as a CT of the cervical spine in the axial view in bone window. Obviously, I always start with patient identification. And this is one of those pictures that we have discussed before. As you see here, this is the trachea. Esophagus you wouldn't see. You see the very dense metal. This is titanium, and you see the pins, metal pins, in a PEEK or plastic cage. Patient had, here you see from the form of that, almost look like a pyramidal kind of shape. So in that sense, I'm assuming this is the C2, but as well you see a very large spinal process. This spinal process is large, and that indicates that's the spinal process of the C2. What I see, skin of the back, I see the fat under the skin and significant amount of muscle there. But I think very significant here in this picture is that the posterior longitudinal ligament here is ossified. We see in this cut, we see the lamina of this C3, and we see almost lamina of the C, their other cervical level. And I think this is all we can see from this picture. If you have any question regarding this picture, please let me know. I'm happy to answer that. I see your comments. Please keep commenting, and I if there's something specifically needed to be known about this, I'm happy to explain it more. You see the spinal canal here. In this window, obviously, you don't see the spinal cord. As a matter of fact, if you need to see a spinal cord, you would have to perform a myelogram. Even in the tissue window, it becomes really hard to say much more about the spinal cord. CT by itself is not the best study to evaluate the spinal cord and the compression of the spinal cord. You can, with experience, you can tell more about it, but generally, MRI is much better, or a CT myelogram, where we put a contrast inside of the spinal canal in the intrathecal space. So let's go to the next picture. Um, Nick, are these pictures that we looked at last time? Because we don't want to repeat the same pictures. Okay, so this is number 95. Is that still an old or new picture? These are the new ones. Okay. Okay. Yeah. Good. This is the identified, so it's not a problem here. So let's talk about this. Christina has a question. I think they are the same as they look. Yeah, they are familiar, but it seems that these are the new pictures. Now let's go to that. We are looking at the CT myelogram of the cervical spine in the sagittal and axial view. As a matter of fact, you see some of the contrast in this structure here. You see it's almost a budding, almost like a crescent shape. Christina, you just volunteered to tell me, type in, where do you think what the structure is that contrast is accumulating between this structure here and this structure here? To make it easy for you, I'm going to tell you that this is the cerebellum and this is the occipital lobe of the brain. So where is the contrast? Can you tell me that, Christina? You can type your answer in. No, I don't see any answer. Here we are. That is one of the sinuses. No, it is not one of the sinuses. Uh, Anybody else can as well. No, obviously the contrast is not in the blood vessel. It's that the sinuses are blood vessel that they bring the contrast back. We put the contrast in the intrathecal space, meaning that the contrast that you see here is part of the CSF space. Now, what is the structure that separates the cerebellum from the occipital lobe? Anybody else? Okay. Will Dorschholz, fourth ventricle? No, fourth ventricle would be here, right here. Fourth, but that's a good answer because eventually the contrast will get in the fourth ventricle. But when we put the contrast in the intrathecal space, in the lumbar space, it goes all the way up and it fills up all the space here, the basal cistern, we call them here, here, and here. We call them basal cistern. This is the fourth ventricle, by the way, here. But the basal cistern, and then it goes around the cerebellum. What separates the cerebellum from the occipital, from the rest of the brain? What is it called? It looked like a tent. What's called tent in tentorium? Exactly. Good job, Christina. So, and that's why you see that shape. Now, do you see why we call the tent tent? Imagine if you turn it 180 degree, it does look like a tent or tentorium in Latin, right? Okay, Neil is saying yes. So let's now I'm pointing to this area, the dark area here. Neil, you want to tell me what you see here in this area? What are these called here? Dark line, which indicates there are air, and obviously this is a seems to be a very dense bone. What is this dense bone called first? Air cavities. These are air cavities in what bone? What is the bone here called? Mastoid cells. Perfect. Well, Christina is killing it today. Um, now, oh my God, that is a horrible. Patient is missing the mastoid on the other side. What is that? What is that disease called that you're missing one side mastoid cells? Obviously, I'm joking, right? So, why do we see the mastoid cell on one side and not on the other side? Who's going to be able to tell me why do we see the mastoid cell in one side and not the other side? Any takers? No, not really. Yeah, that can take the mastoid cells away in one area. Sometimes we go surgically remove if there's an infection there. But the answer is much simpler than that. This cut is not exactly horizontal to the brain and the skull. For that reason, because it's angled, you see the mastoid cell on one side and not on the other side. So it's much more benign thing. It's nothing too complex about this. So you don't have to be worried about that. Now, um, and let's go around, think a little about what else do we see here. This is the mastoid cell. This is part of the temporal lobe of the brain. And this structure here, right here, who can tell me what this structure is right here? By the way, this is the brainstem, basal cistern, which is filling with some contrast. This here, again, air in it. It's a cell. Cella turcica. Good, Neil. Good job, man. And um, and this area here, who can tell me what is that? These are the muscle. Woohoo! No, this is not the woohoo muscle. This is the yeah, masseters. Perfect. Excellent. Excellent. Wow. We have a strong team today. Let's go to this picture here now. Um, this area here is a part of the brain. What is it called? This area of the brain. what what is this part of the brain called here? Yes, brainstem is below it. When you go a little higher up, the brainstem, yeah, brainstem goes into a big bulb. What is that big bulb above the brainstem called? Pons. Very good. What does pons do? Why is pons so big? Who can tell us what is the function of the pons? You see that in this area? It goes. So pons here is practically the terminal, the place that connect the other. Yeah, unconscious processing. Yes, yes. But what it is, it practically is the terminal between the rest of our body and the cerebellum. Yes, all of that. Actually, breathing regulation is mostly brainstem than the pons, but the pons is there are lots of connection between the rest of the brain and our cerebellum. Excellent. Yes. So, um, extra credit for somebody who tell me what this is. Do you see that? Like almost like attaches to the occipital bone. What is that? No, sternocleidomastoid is not in the midline. We have two sternocleidomastoid. They go on both sides. You won't really see that in this middle cut. And obviously, sternocleidomastoid, it goes in the front, connect to sternum right there. So it wouldn't turn around, go back. I know you guys know it. It is a little different cut. This is the back, this is the front. Maybe that's what confusing you. This is not the front. This is the front. This is the no worries. Uh, sometimes I make lots of mistake even after so many years. This is the so-called the nuchal muscle. You're familiar with what nuchal muscle is? Or nuchal? I don't know how you pronounce it in English. In German, we call it nuchal or nuchal muscle or nuchal ligament that connect the practically the rest of the spine here, cervical spine, to the occipital bone. Yes, yes, perfect. Okay, let's go to the next one. Obviously, you would see the ears, right? You see the ears here. And let's go to the next. That is a wild one. Okay, first, I'm going to ask nuchal rigidity comes from. Yeah, Neil is saying that is where the term nuchal rigidity come from. Yeah, when you get really tired there and your nuchal muscle go to spasm, that's where the term nuchal rigidity come from. So, are you guys able to see this picture, all this picture? Meaning the entire coronal view here? Yeah, I'm sure you can see that. Let me maybe turn it a little. Maybe that's a little better. First of all, I want to know who can tell me I'm measuring an angle here. The reason this angle you don't see it exactly, this represent the angle like here. In this program is not a perfect program, but this line here is practically the plane here. This angle here, this line here, presents the angle here. So I'm measuring the angle between this bone and this bone. Even though really horribly visualized, it is the Cobb angle for scoliosis. Perfect. You can measure the Cobb angle in the coronal view, then you call that coronal Cobb angle, or you can measure the angle in the sagittal view, then you call it sagittal Cobb angle. That is important for if you are measuring for hyperkyphosis and so on. Yes, excellent job, Christina. Now, this joint in the back, how do we call this joint? One side is more like normal, the other side is not normal at all, and it almost one goes around. We call that hugging. What's the name of this joint? No, that's not the sacroiliac joint. Look at that. This is and the back, and this is the spinal canal. This is the iliac crest. The iliac crest is far away from this, so this cannot be sacroiliac joint because iliac bone is far away. Facet joint, right? Yes, Neil. Now, what do we call this when one joint turns around the other joint? We have a name for that. We call that hugging facet. It's not a good thing. This is the only thing where hugging is not good. It turns around the other one because its degenerativity is so changed that one facet goes around the other one to stabilize it because our body doesn't want that motion. It's really no good motion there left. So let's look at this here. First of all, we have the hugging facet. This is the myelogram because again, I see the here and you see the individual nerves here. Do you see those dots? Those are the individual nerves there. And here in the sagittal view, you see bone disc, bone disc. You see the air inside of the disc space. Now, who can tell me why, where in heaven or earth, air get inside of the disc space or even inside of the facet? How does air get there? Any takers about how air get now obviously air in we talked about that in one of our meetings about that air inside of the colon and in the intestine is from decomposing material. Fracture, no, even if it's a fracture, if it's not an open fracture, how would the air get into a not open fracture? Now, practically, let's look at that. This is colon, this is stool, and you see air inside of the stool from decomposition. There are two ways of decomposition. There is a bacterial decomposition, like what you see here, and if there is a decomposition, none in our intestine, that would become an infection. That's very dangerous. You have to pay attention to that. But there is so-called mechanical decomposition, like if you hit a normal tissue hard enough, it mechanically decomposes. That the nitrogen from the protein get released, and that's what you see here. You see a mechanical decomposition of the disc or facet. This is a degenerative sign, not a bacterial decomposition. Then you see the back of the bones are not aligned. That's a spondylolisthesis. And you don't see entire scope of the spinal cord. Even if I wouldn't see at this coronal picture, just by looking at this sagittal picture, I would know we are dealing with that scoliosis, because I am not able to see the entire spinal cord and canal in one picture. So it must be a side bending to the spine that prevent me of seeing all of that. Just looking at this picture is enough for me to say we are dealing with a scoliosis. I couldn't measure it, but I could say there is a scoliosis there. Now, we had it in the last meeting. What do you think what this structure is here and here? I want you to see and know that this is ilium. So we are dealing with the lower level, and never rely on one structure to make decision. But this most likely is part of the large intestine. Yeah. Okay, let's go to the next picture. Now, here now, it is higher up in the spine, this structure. What do you think that structure most likely is? This is a little higher up. You see, you don't see the iliac crest anymore, and you see this structure here. Kidney, perfect. Good job. Now, let's go to the next picture. See what else do we have there here. Okay, here we go. Let's get a little away from the spine, not concentrate only on the spine. Again, air in our intestine. What is that less white material that practically encases all our intestine inside? What do you think, guys, what do you think what it is? Same density under the skin. Well, it is peritoneal space, but what is the structure in the peritoneum? It has, look at that, the density. What is the material? What do you think? What is the tissue that is here? By the way, we have it right under the skin as well. Like, is it bone? Is it a little to the left? Like this? Oh, yeah, I see. You guys weren't able to see all of that. I'm just. Okay. What is this material here and here? What do we have under the skin? In the skin, under the skin, yeah, adipose tissue. Now, what is a big structure? This is the subcutaneous fat, perfect. But here in the belly, we don't have subcutaneous fat. What is omentum? Perfect. That's omentum. And omentum is practically a big, like almost like a curtain. Have you seen that in the anatomy lab? It's almost like a curtain. What it is, it's lots of fat between our bowel that almost like, making the bowel moving against each other like lubricates, making moving them against each other easier. Nature is a fantastic thing. Yeah, if you see that the omentum has lots of the globule of fat, and it goes between these all the folds of the intestine, and when they move, it makes the movement there easier and better. And the way as well, it's fat. It's one of your area that you accumulate fat for your metabolism. Sometimes too much. Like look at that here. There's a lots of omentum fat here. Exactly. It protects and nourishment the organ, but as well is we have found out that there are some immune factor in the omentum that actually, if you have if you have a peritonitis, if you have a bowel rupture, that actually omentum walls off the infection. It's amazing how what our body is able to do. That if you have a infection somewhere, omentum create a wall, a barrier between that area and the rest of the peritoneal space. It's an amazing thing. Now, let's look here. Um, what is this structure, round structure right here? What is this? Abdominal aorta, yes. Now, it is round because the pressure is high. By that definition, where the pressure is not high, that structure is not necessarily round. It can be any other shape. So, what is that? Yes, peritoneal cavity can be used for dialysis, Neil, correct. Inferior vena cava, correct. Um, for that reason, you need to understand the inferior vena cava, it can be round if there's lots of fluid in it, or it can be any other shape if there's pressure on it. What is the typical pressure in the aorta? Typical pressure in the aorta, what is it? I'm talking practically the other name for that is systolic diastolic blood pressure, correct? In the aorta, about somewhere between 70 and 120, something like that. So it takes a lot of pressure to make change the shape. Exactly, 120 systolic. About now, what is the typical pressure in the inferior vena cava? Obviously, it is much lower than the pressure in the aorta. What is that pressure? Somewhere between. Oh no, sweet Lord, if you have that much pressure, our veins are going to rupture if you have 60 to 80. It's much, much less. No, it is much less because blood is returning. If it was a high pressure, our, our body couldn't push the blood back to our heart. It is somewhere between 6 and 12. So that is the amount of pressure it is in our inferior vena cava to because blood is returning. Okay, so what else do we want to see here? Any question regarding this picture? Okay, next. But Christina, don't hesitate to ask question. The best experience to learn is having it wrong because then you learn it right. Okay, I want you to throw wild things out there. It is a good thing. Okay, don't lose your courage to throw up out there. Some people they don't want to do any mistakes, so they don't do anything. Okay, this is the right time to have all the mistakes. Even as I'm like for 30 years a surgeon, I make mistakes every day and I learn from them. Okay, it's a good thing to make mistakes. So what is your advice for students who are hesitant to make mistakes? To make them as many of that as you can. You never forget the learning from your mistakes. Okay, I was always throwing wild thing in my the thing and so on, and people are laughing and so on. But I learned from every single of them. Okay, just don't let any mistake go to waste. Learn from every single mistake. For a mistake will be made. That's good one. So here, um, this structure here, we talked about it last visit. What is that? Who's going to tell me what that is? This structure right here. Trachea. Yes. But if that's the trachea, what is this? No, yeah, it could be esophagus, but it would be unusual to have that much air in esophagus. Most of the time, you don't really see esophagus. I mean, except if you have esophageal tumor, it is hard to see esophagus because if you have seen esophagus, we have cadaver lab, and I showed that in one of our cadaver lab. Ask Amanda to give you access to one of those videos. Esophagus is very, very flimsy, and except you're putting a lot of air in it, it's for 99.99% of the time, esophagus is a thin line that is extremely hard to visualize anywhere. And I think, and I'm not sure about that, but look at that. That seems to be the cut. And it seems that that structure use other cuts to identify. This is what I'm trying to tell you. If you are not sure about the one cut, go in that cut, go up and down, correlate it with other things. In this case, you might be right, Christina. It might be esophagus because I see that structure is behind the trachea. It's going up and down. It is very unusual. No, it's not a vein because the content of it is uh, black. I think you might be right. In this case, it is probably esophagus, but this is unusual. I want to tell you that is very unusual to see esophagus, but big trachea, something behind it, you might be right here. Okay? Generally, it's extremely unusual to see esophagus. Now, here, what is the structure here? Yes, good one. What is this structure here? In front of the heart. Yes, swallowed. That might be swallowed air. I mean, how else is going to air to come there? But I just want you to know that's on. Yes, sternum. Unusual to have air there. So this is sternum. Correct. Um, Here is the lung, but you don't see anything in the lung because this window is a bone window. That's why you don't see much. Now, this, first of all, let's start with basic thing. What is this? How would I present this? What modality is this? MRI of the cervical spine in the T2 in the sagittal and axial view. You see now the cerebellum, and you see this division in the cerebellum. You know, cerebellum is very organized, and you see this section of the cerebellum. Now, you see here, um, actually, I think that is most likely the basilar artery here. And then you see the fat here, again, the nuchal muscle and ligament. Correct. T2 highlights mostly water, but fat as well is white in T2. Now, you don't see much here. Now, you see that MRI, and yeah, then you see something here. Hmm. That seemed like, like almost like a little destructive tissue there. We talked about it last time. If you see in the C1, C2 area, in dense area, no, it could be a tumor, but in this case, it is not. Um, this we call that, especially in this area, if you see a lots of tissue that bulges out, it, we call that pannus. Why not use the T2 images? Now, Neil is asking, what is the point of having T1 and T2? Why not only use T2 images? Well, T1 images, we call them anatomical views and anatomical pictures, and T2 we called pathological pictures. And maybe in one of these days we go back and look at that. T2 shows wherever uh, there's more water. More water means edema. Edema means some process brings more tissue, water there, and that shows where there's a pathology. Whereas T1 shows more anatomical view, meaning that the borders, many of the borders between the areas are better visualized in T1. They show different things. um, I know that is not a big hit, but if you now understand how the T1 and T2 produced, you understand what do they represent and why it is important to see them both. Um, Neil says T1 anatomical, T2 pathological. Yes. Okay. Yeah. So let's go to the next. So if you have a pannus, we call it pannus, it's suggestive of what kind of disease? Rheumatoid arthritis. Okay. Remember, thick area around C1, C2 may be a good indicator that you are dealing with degenerative changes related to rheumatoid arthritis. Okay, here. So, let's see if you have any new information from here. No, I think there's not much information more that you can get from this picture, except there is a small little disc herniation in the upper thoracic region. And you see that the fat between the muscle tissue here. Okay. Now, I'm going to ask you a question that uh, maybe has nothing to do with the with the medicine, but um, you all have had a steak, right? And if you have the steak, you know that fat tissue between the muscle fiber. Steak most of the time is the paraspinal muscle cut in certain way, and there are different names for that. And if you have a steak next time, please look at the fat dispersion in the steak, that we grow our steak or our cattle the way that they have more fat between the muscles of the paraspinal muscle, and that fat give flavor to the steak, and that's more fat you have, more actual flavorful your steak is. So next time you eat a steak, think about the fat muscle that you see here. If you take a picture of that, next time you get a good steak, you will see very similar fat dispersion between the muscle. I hope I didn't destroy your taste for your next steak. So here, let's look at this one. Okay, this is as well an MRI of the T2, and you see that something is done here. Who can describe what is done here? This doesn't look like the rest of the spine. There's a dark space here. In the T2, we know that the dark space means less water. Less water means that possibly this is not a biological tissue. Diffusion, correct. Diffusion, there is a cage, inserter, spacer here, and that material doesn't have any fluid, no protons, and I wouldn't say this is a disk replacement, Neil, for a good reason. If you have a disk replacement, most of the time, part of the disk replacement is a very hard, dense metal. That would make a huge shadow here. This is a cage, not a disk replacement, because a disk replacement has a dense metal to be more durable, and then you would see a huge shadow there. It's a cage, it's a disk spacer rather than disk replacement. um, these are two different things. Disk replacement or artificial disk, it allows motion. This is just a spacer to make sure the bone is not on bone. You see part of the shadow of the screw. You see previous scar from the surgery. You see the cauda equina, and you don't see much here because the way this image is obtained, it's concentrating on the spine and not on the abdominal cavity. Okay, we are going to look at few more pictures, but we are going to stop very soon. This has been almost 40 minutes. Now, these are the same pictures, and this is the last picture of we are going to look at. So, what is this disease called? The L5 on S1 is shifting forward. What is this disease called? Do you know the name of disease where the bones are not aligned? Anterolisthesis, perfect. Or spondylolisthesis. You can call it anterolisthesis or retrolisthesis, or you can call it spondylolisthesis. Okay, I think we should stop right here. And here you see the cage again, the metal cage. This is CT, obviously, because in MRI you wouldn't see that. And you see the cauda equina, you see the conus medullaris, you see air in the large intestine. This is not air. You see the screw, it is aligned, that line, it's so-called the metal artifact from the screw. How do I know that? Look at the line that going across, and that dark is right after the metal. So it's not a true finding, it's a artifact, the metal artifact. If you remember, we did a session about the how CT image is produced, how the physics of CT is. If you understand that, you understand why this dark is after the metal and not real. Okay, I take one or two questions, then we call it a day. Any question? So, I have a suggestion. We are going to improve on this. This is our first one. We are going to next one that we go again interactive like the last time. So Neil says we should continue to do this every week. Well, we should do it bi-weekly. And come up as well with some things you want to know. I think we can do much better than this. In the center of the photo are those lateral muscles or psoas. In the center, okay, let me go see if I understand the question. Christina is asking in the center photo here. Uh, Christina, are you talking about this muscle here? Yes, okay. That is the iliopsoas muscle. There are two muscles. Um, and you don't see the differentiation in this picture, but in some picture, actually in some patient, you will see the differentiation in the psoas and iliac muscle. That they are together in one capsule. That's why we call them iliopsoas. So, yes. Well, thank you, everybody. Okay, this has been great. There will be a recording of this, I'm hoping, so that all of you can see it. But otherwise, you guys have a great day. Okay. Let's see end stream. Oh, quadratus lumborum. Neil is asking, what is the? These are completely different muscles. They are in different location. We will show it to you, maybe an anatomical picture next time. Quadratus lumborum and ellipsoas are just different muscles. You guys have a great day. Okay. Bye bye.